Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illness, mainly those that would qualify for either palliative care or hospice care. Those are two separate services. I'm also a certified end-of-life doula through the International Doula Life Movement, as well as one of their instructors in charge of their continuing education program, as well as creating a brand new course that will be available in early 2026 based on my book, Crucial End of Life Discussions, Conversations. This is going to be a follow-up video from today on the topic of palliative care. And if you're new to this channel, welcome. Thank you so much for visiting. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Shouldn't we be aware of the options that we have available before us on our journey through life so that we could live life to the fullest, and that when death comes, we're not afraid, we're prepared. So if these are types of videos that you like, please consider subscribing, hitting the bell notification below. Please like, that does help the YouTube algorithm. I do want to take one moment before we get into today's topic, which is going to be about my phone call yesterday with Dr. Andy, I would struggle with this. I go Dr. Andy, Dr. Arari. He said, just call him Andy. So I had a wonderful phone call, but before I go into that and how this relates to palliative care, which was shown earlier this morning, let's stop and ask, what are you grateful for? I find by focusing on points of gratitude that allows us to build resilience so that when darkness falls upon us, we're more likely to rise through or not be suppressed or hit down as far. We bounce back better. So in terms of what I'm grateful for, I have a laundry list. One of them is Andy posted an article uh, late last week trying to raise awareness for palliative care. And this is very fitting because I'm doing a project for Madison County, Kentucky at large. I was helping somebody that's trying to, a fellow end-of-life doula in Nelson County, Kentucky, trying to find resources for her client who needs palliative care. So I'm grateful that Andy called me, and I now have his number, and he's now programmed in. And so I'm grateful for that. I'm grateful for, this is kind of happy sadness, for a family that I've been helping with in Ohio. If you're watching this, you know who you are. My heart goes out to you. We were talking yesterday, and you said it was wonderful to have your own personal hospice nurse in terms of a doula experience. Uh, and I'm grateful for you, but their journey ended yesterday with a loved one took their last breath. And I was grateful to be able to be a part of that journey, explaining the dying process, and this was done remotely, working through anticipatory grief, what the different signs and symptoms mean, without being able to give a timeline that when you hear the death rattle, if there's no congestive heart failure, it is typically an extremely late sign. So I was hoping it was going to be under the 12-hour mark, and it was approximately, but it can go out to 36, 72 hours. But their journey, a portion of it came to a close. I say it that way because there's never a genuine end to grief. It comes in waves, it comes and goes. We're happy for the loved one who's no longer suffering, but we are here yet standing. For those of us who believe in Christ Jesus, and this was a family who did, They know where he went, and they know that they're going to meet him when the time comes. But that doesn't stop the hardship and the aches inside that happen. But I'm grateful to have been a small part of that journey. So let's get into the topic of today's video. I'm not doing the formal talking head video. I'm doing this tutorial video. And I'm starting with Andy, because Andy I appreciate so much. I think it was either in November or December, he endorsed my Mastering Hospice Eligibility book. And in yesterday's discussion, said that, he really enjoyed the overwhelming majority of my books. Uh, and he believes that I should have actually titled them in a way that it would be more noticeable that these books apply to everyone who is in hospice, not just the nurses. And Andy, I appreciate you. I'm thankful for your call. And I agree with you. And we did talk about the um, caveat. I really appreciate Amazon KDP's ease of use, but they don't allow you to retitle without unpublishing and publishing brand new. You lose all your ratings, you lose all your reviews. And even when you do a second edition, it's literally considered a brand new book. That's its own venue. I don't want to go off track. But Dr. Andy, who is a medical director and a speaker, I cannot speak highly enough of Andy. Um, he's an amazing individual, and we share many beliefs. We were talking about, and I do want to hit on this topic before I go too much further. I don't want to forget. I took notes during our call. My short-term memory is like this, but I do want to mention this before we get into palliative care, because it is a hot topic. It is a hot topic. It's a controversial topic. And as I share what I'm about to share, I want to be very, very clear. I'm not taking sides. I have my own personal point of view, but I want to bring out what Dr. Andy, well, let me give you a backstory and then give out what Dr. Andy shared, because the backstory is based on Dr. Andy having a post maybe a month and a half to 2 months ago. This is being filmed on Wednesday, August 13, 2025, and being published on YouTube the same day. So, Dr. Andy, I should say just Andy, did a a LinkedIn post, memory confusion, a LinkedIn post where if there was early adoption of palliative care as soon as possible, before the symptom burden. Meaning, let me give the example. You're told that you have breast cancer or prostate cancer or whatever, or you have chronic kidney disease and we're recommending dialysis. So that's the starting point. You've not started treatment. If palliative care started at the same time you started treatment, or within just like days to maybe a week or two, there would be less of a push for medical aid in dying. Because if you think about medical aid in dying, people, it's an emotional driven, I'm not saying good or bad, it's an emotional driven concept. People will often post on social media or say in person, we treat our pets better. Why should human beings be allowed to suffer when we can go and say our pets, let's euthanize? I'm going to just use real words. Let's euthanize our pets. They're suffering. They don't need to suffer. Why? Why? So here, with palliative care, we're going to go into that in a moment with part of what the issue is. We had a very good phone call. But if there is minimal suffering, I can't say, I do my best to be transparent, I do my best to be honest. Uh, no minimal exaggerations, minimal, like the big fish. We can never say there will be zero suffering. But if we could take the suffering and make it to that, like most people who are adults, I can't speak for children, but most people who have adults, we've had colds, I'm dealing with allergies right now. Uh, we've had the flu. We've had various illnesses through our lives. And the overwhelming majority of them, and I'm only speaking for me, it wasn't like, I am suffering so much from the flu, I just want to die. I'm not trying to minimize things. I'm just trying to be very transparent and very real. Or I'm struggling with my allergies, I just want to die. We have a level of suffering that we can tolerate. I'm not saying we should. You're you, I'm me. I'm not saying what you should be able to tolerate. Please, please bear with me. But if we can minimize the suffering to be the very least amount, that you could have a quality of life. You could go on vacation. You could read a book. You could write a book. We have I don't want to name names because I don't got permission for certain things like this, but we have a gentleman, sorry, we have a gentleman who's taking Pam Carter through the International Dual Life Movement's advanced care planning class. It started yesterday, Tuesday, August 12th. I do not know if there's still room in the class, but we had an amazing first show. Well, I think we were around 30, almost 40 people in the class last night, and it was just the introduction and orientation. So I'm sure that as we go through, more people will be popping in. Uh, but this person has been battling cancer. So if your suffering is really pushed down to where it's bearable, you can go on living and plan and enjoy whatever life remains. So Dr. Andy made it that point. So when we're on the phone yesterday, not to belabor this, we're on the phone yesterday, he mentioned the other dilemma for medical aid in dying that I did not know about. I didn't know this. I'm the hospice and palliative care nurse. I'm the end of life doula. I am not a doctor. Andy, Andy over here, you can't see my hand pointing to him. Andy over here is a doctor. Medical aid in dying, legal in the states where it's available, requires a doctor to write a script. Huge, huge fine print. If I could make like what the asterisk would look like, fine print. The doctor has the right to say no. The doctor is not forced to write the script. The doctor has every human right. This is a civil and human right. I want to be very clear with this. This is an area where I didn't know what Dr. Andy was sharing, but I do know when it comes, for example, with abortion, medical science confirms human life starts at conception. As a registered nurse, I have the right, and I've told my employers, like when I worked at Harrisburg Hospital, for example, I will not, zero, will not participate in an abortion. I will not kill, because that's what it is. I'm not trying to tell you this. I'm not trying to turn this into a political discussion, but I, Peter, will not kill a baby. I will not help somebody kill a baby. And as it relates to medical aid in dying, I've had hospice patients where it is not legal, where they brought it up, and I said, I love you platonically, but if you were to go down this route, I will not take away your choice. But I could not be your nurse because I will not aid in the process. I'll not be a part of the picture. And I'm not trying to get into an argument because I know somebody would say, but you could be the one providing them comfort while they're going through this. That's a fair point. But let me get back to Andy's point. Even where it's legal, you cannot force the doctors to go and violate their conscience. I want all of you who are looking that if you do support it, and I'm not trying to say don't, I'm going to be very clear. I want to be very clear. Everybody has human rights. No one person's human right supersedes another's human rights. So you can't have the possibility, no matter how small the possibility, that if it does become legal in a state, that every doctor in that state rebels. That is their human right. It says we're not going to write the scripts. Please be aware of that. I was not aware of this. I didn't know this until Andy brought this up. The doctor has the right to say, not on my watch. Be aware of that. And just as a side note, and I've run into this with palliative sedation, and this is one where I believe palliative sedation, I participated in it. To me, it's night and day different than medical aid in dying. There are similarities, but I fought for palliative sedation. I've had doctors say no. I've had doctors go so slow. I still remember the one doctor, I'm not going to name them because I'm not into shaming people, but here, I'm not Dr. Kevorkian. And I would give him 5 more milligrams. Okay, you can give him 10. And the maximum dose, by the way, is 1,600 milligrams, and 5 to 10 milligrams here or there is like drops. Anyway, that's its own rabbit trail. But let's go further into the discussion about palliative care. So this website. I'll put it in the link in the description below. These two websites here are huge. They are the major players out there about palliative care. So let me read palliative care. What is palliative care? Palliative care is specialized medical care for people living with a serious illness, focused on providing relief from symptoms and distress of the illness. I cannot emphasize enough, genuine palliative care is symptom burden driven, not prognosis driven, not life limiting driven. If you hear the words life limiting, that's the same thing as prognosis. You're talking hospice. Please don't. Palliative care, on this page, on this page, you will not see the words life limiting. You will not see the words terminal. I'm pointing that out because I'm going through my own struggle. I'm so glad I'm living in Kentucky. I'm from Pennsylvania, but there's parts of me that want to go and my brain explode, because when I'm calling around to different places, I get places that they're very well and respected, and they're doing a wonderful job. So please be aware. I'm not trying to pick on the place or the job that they're doing, but my mind goes because, oh, we only do it for this diagnosis. Do you see a diagnosis on this page? No. Or this? No. And then they'll go, it's this diagnosis and life limiting. And I'm like, are you kidding me? And I don't say that to them because I'm not trying to shoot the messenger. And the messenger made my day because they sent me a huge spreadsheet that's like, this is wonderful. And I was able to use that spreadsheet to direct somebody in Nelson County, Kentucky, to Hosperis Health. Hosperis, no, I'm sorry, I think it's Hosperis Hospice. It'd be Hosperis Hospice and Health. It's Hosperis. But it's like, this is hospice. I mean, this is palliative care. Any stage, any stage, alongside curative treatment. That is genuine palliative care. And then again, with get palliative care. Any age, any stage, curative treatment. And so, but part of when, Andy and I were talking and I'm going over, what's going on here? Like, this is what I'm running into in Kentucky. And I actually, Jennifer, who's one of the leaders of the Council for Advancing Palliative Care in the state of Kentucky, got back to me yesterday, gave me another person's name, and I ended up writing them towards the end of the day. And I told them at the end of my email, I understand this is going to come across as venting, but I'm seeking help, because what I'm running into is families in Madison County, Kentucky, that genuinely need the right type of palliative care. When I say right type, I'm talking right here. I'm talking any illness. I'm talking symptom burden driven, not prognosis driven, not diagnosis driven, symptom burden driven. That's genuine palliative care. And I'm running into roadblocks. I'm running into roadblocks with certificate of need, and I'm running into roadblocks with it's diagnosis driven, and then it has to be life limiting. And I'm going like, you're describing hospice. We're talking palliative care. So Dr. Andy, and I apologize if I'm going down many rabbit trails and with this, but Dr. Andy is like saying, what, Peter, palliative care is paid for by insurance. Now, I want to put a demarcation point, like the line. If you watch map, you look at a map and like the line, the imaginary lines between the states, because if you're driving from state to state, aside from the welcome signs, you're not going to see demarcation lines. So Medicare that has a hospice benefit, Medicare is a type of insurance, but it's broad based from a point of view. I'm not saying it's wonderful, because I know there's a foot push for Medicare for all, and I don't think you know what you're going to get. But when it comes to private insurance, the insurance company gets to define what they're willing to pay for. They get to define, I understand palliative care is supposed to be this, but in order to keep their costs low and their profits high, and I'm not being facetious, if you look at how much money the CEOs make, and you look at the problem that we have with the pharmacy benefit organizations that have taken over pharmacies, and we're talking billions of dollars. I I don't know how to word certain things. I am a capitalist from a point of view, but there's parts of me that there's certain areas that capitalism should not be involved in, and to me, that's healthcare. Uh, I'm not saying healthcare should be socialist, but we need we need a reboot desperately. And I'm hoping that for people that you are watching this as a viewer, I'm hoping that you become part of the solution. Because part of the reason I had this call with Andy, and I'm emailing Jennifer, and I don't want to mispronounce the name of the her boss that she gave me that I emailed yesterday. My short-term memories like this. I'm trying to be part of the solution to this, not part of the problem for this. I'm just like, how do we raise awareness? So he's saying that it's paid for by insurance. Uh, Almost everybody has a different definition of palliative care. Even though you go here and you go here, these are the definitions. But they'll come up with their own, and that doesn't help anybody. I'm being very honest and serious. It doesn't help anybody when you don't have the same term. Palliative care is not hospice. Hospice is always palliative care, but palliative care itself is at any stage symptom burden driven. So one of the hopes that both Andy and I have, and we realize there are going to be problems if this ever happens. Be careful what you pray for, be careful what you wish for. Is that the Medicare benefit would expand to not only be hospice, but palliative care too. I think it would, we both were talking about it, would solve so many problems. I have a book, Mastering Dementia Admissions for Hospice. And part of the reason that I wrote that book is Medicare. You're talking about like something coming out of both ends, mouth and anus. So Medicare will go and say the longer somebody's with dementia, any type of dementia, the longer they're on hospice, the sooner they start hospice, the longer they save. Some studies say $8,000. Some studies say $27,000. I think that's a year of in the system. So, but that's coming out of one mouth, and then coming out of the other mouth is if you admit the loved one with dementia when they're not 6 months or less to live, you're committing Medicare fraud. You whack, whack, whack on the hand, and how dare you? Um, so they're speaking out of both ends of their mouth, so to speak. Um, and that's why I wrote the book Mastering Dementia Admissions, is to how to help my hospice team members. How do you know when the loved one with dementia is the most appropriate time to admit that they're not 18 to 21 days, but then they're not necessarily, oh, like I've heard cases where, you know, they've been on 4 years, 6 years. I cringe on the 6 year mark. Something is definitely wrong if they're on that long. But if we can get the Medicare benefit to expand it to cover palliative care under the genuine definition of palliative care, the genuine definition of palliative care, then we're benefiting society. We are benefiting everyone. So we had a good conversation about that, the scatter definitions, and this is where I'm going to come to an end, because I know this is long, and I'm trying to keep some of my videos shorter than normal. So where I want to come in the ending portion, I'm asking you, please be a part of the solution. And here are the tasks before you. One, I want you to please, and I'm going to put in the description, in the links below, these two websites. I want you to please become aware of what is genuine palliative care. I want you to know the right definition. I want you to please spread the word in your neighborhoods and your communities. And as you're talking to healthcare providers, I want you to spread the word. I want you to be asking, saying, when you go to your doctor, you know I might not need palliative care, but here's my understanding of it. What's your understanding? How are you helping people in this area? I want you to start challenging, like when you go to places that offer palliative care and they're telling you that it's based on a diagnosis and it's based on a life limiting, which is prognosis, politely, I appreciate your services, but are you aware that's not genuine palliative care? Genuine palliative care is symptom burden driven without any life-limiting conditions. You're actually creating a type of hospice care that's not. You're providing help. So I don't want to minimize what, for UK Health, for example, Matthew West, I can't thank you enough. And they're well known in the area for the benefit they're doing for their cancer clinic for palliative care, but it's not genuine palliative care because they're restricting it to life limiting and only for cancer. So get out there and spread the word. Get out there in your community. I was having a discussion with a fellow hospice and palliative care nurse that's also a graduate of the International Life Movement. Get out there, and I'm not saying anyone be like me, but this is where it's like, go out there and create your own directory. And I gave her a link to mine. I'm not like, here's mine's free. I'm not trying to say I own it. I'm trying to get it out there. But be part of that solution. Be part of the promoting the awareness thereof. So I thank you for your time. I thank you for watching. Take care, and God bless.